Over 40% of adults in the United States are currently classified as obese, creating a clinical volume that exceeds the capacity of specialized weight management centers and lands squarely in primary care. For decades, physicians were trained on the obesity treatment pyramid. This model mandated a rigid escalation of care based strictly on a patient's body mass index, beginning with caloric restriction and only introducing surgery at the highest BMI thresholds. Modern care has abandoned this hierarchy. The pyramid has been replaced by three foundations: lifestyle intervention, pharmacotherapy, and surgery, each considered an equal option from the start of treatment. The transition is driven by a clear understanding of why intensive lifestyle changes often fail. When a patient loses weight through willpower alone, the body triggers compensatory survival mechanisms, including a marked increase in the hunger hormone ghrelin and a decrease in energy expenditure. This physiological resistance to weight loss marks the transition in clinical consensus. Effective management involves treating a recurring biological pathology rather than addressing a series of behavioral failures. Using body mass index as the sole diagnostic tool is statistically insufficient. It fails to quantify actual metabolic risk or provide a clear picture of a patient's unique health status. The new standard of care focuses on specific, evidence-based percentages of total body weight loss to drive health outcomes. This line graph maps how weight loss percentages trigger specific health milestones. Losing 5 to 10% of total body weight is the threshold required to reverse prediabetes and prevent the development of type 2 diabetes. Moving into the 10 to 15% range delivers measurable reductions in cardiovascular disease and obstructive sleep apnea. At 15% and above, we begin to see the remission of complex conditions like metabolic dysfunction-associated steatohepatitis. Prescribing interventions to hit these specific health markers addresses patient risk directly, bypassing the clinical noise of the bathroom scale. Previous generations of medications were largely ineffective. Orlistat, for example, typically produced only a 3% reduction in weight and was limited by significant gastrointestinal side effects. Modern pharmacotherapy utilizes the gut-brain axis. Natural GLP-1 is a hormone that slows gastric emptying and signals the hypothalamus to reduce the drive for food. However, native GLP-1 is extremely fragile. The body breaks it down in roughly 2 minutes, making its natural form useless for chronic management. A second hormone, GIP, regulates energy balance through different pathways. It improves insulin sensitivity in fat cells and influences the brain's response to leptin. Modern incretin-based medications are engineered to endure. They fix the body's internal fuel gauge by overriding the brain's metabolic downregulation. Currently, Semaglutide 2.4 milligrams serves as the absolute clinical benchmark for monoagonist therapy. In the STEP clinical trials, patients achieved an average body weight loss of 15% over 68 weeks. Crucially, the SELECT trial proved that semaglutide reduces cardiovascular mortality by 20%, providing heart health protection even in patients without diabetes. Tirzepatide 15 milligrams introduced a different mechanism as a dual agonist, targeting both the GLP-1 and GIP receptors. The results in this comparative chart show the increase in potency. While semaglutide averages 15% weight loss, the SURMOUNT-1 data for tirzepatide shows patients reaching 20 to 25%, with female patients showing a significantly more robust response. Data from the SURMOUNT-OSA trial also showed a significant reduction in the apnea-hypopnea index, leading tirzepatide to receive secondary FDA approval for moderate to severe sleep apnea. These dual agonist medications are now producing results that approach the efficacy of bariatric surgery. Emerging oral non-peptide molecules bypass stomach digestion entirely, directly entering the bloodstream. This unique pathway eliminates the need for injections, fasting, or specific dosage timing. These pills yield roughly 10 to 12% weight loss, making them an effective entry-level tool for patients who prefer to avoid needles. But regardless of the medication, rapid weight loss creates a specific medical concern regarding body composition. This pie chart shows the typical ratio of weight loss. For every pound lost on these medications, approximately 25% of that weight is fat-free, lean tissue. If physicians prescribe these tools without mandating resistance training and high protein intake, they risk causing a sharp loss in muscle mass and accelerating sarcopenia. Providers use a decision matrix to match drug mechanisms to a patient's metabolic profile. Patients with cardiovascular disease route to Semaglutide for mortality benefits. Those with severe sleep apnea route to Tirzepatide for respiratory risks. Patients with needle phobia route to oral options. Successful long-term use depends on proactive symptom management. This includes daily fiber supplementation to ease GI distress and increased water to facilitate fat hydrolysis. Precision in obesity care depends on aligning the medication's mechanism with the patient's underlying cardiometabolic dysfunction. This graph from the SURMOUNT-4 trial shows the initial weight loss phase on incretin therapy. When stopped for a placebo group, the graph diverges sharply. Placebo patients regained 2/3 of their lost weight, while those on medication maintained their results. This regain occurs because stopping the treatment allows hunger hormones like ghrelin to surge back, while metabolic rates remain lowered. These medications act as chronic management tools, similar to statins for cholesterol or ACE inhibitors for blood pressure. They treat the condition without eliminating its biological cause. Integrating complication-centric diagnostics with sustained incretin therapy allows physicians to actively suppress the morbidity trajectory of the obesity epidemic.